Good evening. I'm Dr. Matthew Siljander, and thank you for joining me this evening. We'll be talking about hip replacements, and hopefully by the end of it, you'll be able to answer this question, and that is, when should I consider hip replacement? We'll have some time for questions at the end. So large joint arthritis is common. It affects up to a quarter of people greater than 70 years of age. As you can imagine, it affects an aging population. It has a poor natural history, and when it occurs, it can affect all facets of a patient's life. Total joint arthroplasty, or hip replacement, has really revolutionized the treatment of arthritis. It reliably improves pain and restores function, and has proven long-term durability. Some studies have shown greater than 90% survivorship up to 20 years out from hip replacement. However, it does require appropriate patient selection. This includes history, an exam, appropriate tests, and ultimately leading to a diagnosis. So we don't operate on patients unless we have an appropriate diagnosis. Part of the history includes things like the character of the pain. Is it sharp? Is it burning? Is it dull? The location. Most commonly for hip arthritis, it's located in the groin, but it can be in the buttock, the thigh, the trochanter, or even anywhere down up to the knee sometimes. Does it radiate anywhere? What aggravates it? Is it walking? Is it stairs, running? What makes it better? Is it rest, anti-inflammatories? How long has the pain been there? Has it been years, months, just come on? And patients must have moderate to severe pain before surgery is considered. The other things that are important are things like ambulation distance. How far can you walk? Do you require use of an assisted device like a cane, a walker, a walking stick? Do you have trouble getting in and out of a chair? Are stairs difficult? All these are intended to assess your functional limitations before surgery. The other thing that's important is ruling out other referred symptoms or extra-articular or outside of the joint type symptoms. These are back complaints, vascular symptoms, radicular pain, or what you can think of as sciatic type pain, or neuropathies. You have to have realistic expectations. Know the limitations of the proposed surgery. What are the long-term results? Have some thought into the hospital stay after surgery. And know that joint replacement is not a panacea. It doesn't solve all of your problems. Many patients fear surgery, and this fear of surgery can be overwhelmed by the pain and disability they get because of this hip arthritis. Radiographic or X-ray evaluation is important and is an integral part of making the diagnosis. On this slide, if you look to the left, you see a hip, and this hip is largely a normal hip. You see above the ball, the spherical ball of the femur, you see a dark space above the ball, and that dark space represents cartilage, which doesn't show up on X-ray. Now turn your attention to the picture on the right side, and this is an arthritic hip. You see that joint space that was there is now gone. It's just a white space where the space has been obliterated. You see kind of a beaking of the bone above the hip, and that's osteophytes or bone spurs. So who is a non-surgical candidate? This is a patient with pain that's largely due to bursitis, tendinitis, or other soft tissue type pain, which is always treated without surgery. Patients with chronic pain syndrome, neurovascular problems, or patients that are too medically unstable to undergo surgery. Who is a good surgical candidate? We've kind of discussed this a little bit, but that's somebody with pain that's moderate or severe and refractory to non-operative measures, is functionally limited in their daily activities and has pain every day, and has radiographic or X-ray signs of hip arthritis. And as I said, it's important that these patients have tried and failed non-operative management before considering surgery. What are some non-operative management measures? Well, oral medications are one, and this is commonly anti-inflammatory medications like Celebrex or ibuprofen or naproxen or things like that, or people that are unable to take anti-inflammatories. This would include things like Tylenol. Typically, narcotic pain medications are not a good idea for hip arthritis. Injections, although for hips as more so as compared to knees, injections are more diagnostic. And what do I mean by that? So patients can have symptoms that are coming from potentially hip arthritis or bursitis or coming from the back. And if it's unclear what percentage of pain is coming from the hip joint, an injection is a good idea. Even if you get pain relief for 2 days, a week, a short duration, that can give you an idea of what sort of pain relief you could expect after hip replacement. Let's say you had an injection and you relieve 70% of your pain. Well, it's a good indication that 70% of your symptoms of pain are coming from your hip arthritis itself and 30% from something else. So that's the type of pain relief you could expect if you had an operation. What are some non-operative measures? Weight loss, although this can be hard to do. Exercise or physical therapy, but this can really honestly sometimes exacerbate your symptoms. Assistive devices like canes, walkers, walking sticks, especially for longer walks or walks on uneven ground, definitely helpful. It can offload your joint, but often not always well accepted. Now, if you're at the point where you're considering surgery, there's a variety of important surgical considerations, and here's just a few of them. One is weight loss if you associate with obesity, smoking cessation, diabetes, and potentially other social factors. So why is weight loss prior to hip replacement important? Many studies have looked at this, and there's a correlation between increased BMI or weight and the risk of complications after a surgery. If you look at these charts here, the top left chart shows the risk of dislocation with increasing BMI. The bottom left shows a risk of infection with increasing weight and BMI. And the one to the right shows the risk of reoperation. And what you notice here is that as your weight or your BMI increases, so does your risk. Not only that, as you get to a BMI of around 40, the rate of increase becomes exponential. So the important thing with weight is we want to do this operation for you to help relieve your pain, but we want to do this as safely as possible. What about smoking? A variety of studies have also looked at smoking and its risk related to surgery and joint replacement. Active smokers have a higher risk of wound complications. And as you can imagine, if you have a higher incidence of wound complications, this can lead to increased risk of infection, which could create a bigger problem than you already have. Former smokers or those people that have quit smoking have no increased risk as compared to non-smokers. What about diabetes? Patients with diabetes are more likely to have post-operative complications, including things like increased hospital length of stay, joint infection, need for reoperation, and even poor functional outcomes. There is a very high importance of well-controlled glucose around the time of surgery. In fact, it is recommended to consider postponing joint replacement surgery if your hemoglobin A1C, which measures long-term glucose levels, is higher than 8 because of an increased risk of infection. What about other social factors? Your living situation. Do you live alone? Are you going to need help post-operatively? And if you do, is that available for you? Is your bedroom or bathroom on the second floor? Would you potentially need to spend some time in a skilled nursing or rehab facility after surgery? Do you have the time and capability to take the time to recover after an operation like this, socially wise? These are all important things to consider as you're reaching a decision about if and when to have surgery, and to make sure you've planned for all these factors. So when should you consider a hip replacement? As I mentioned earlier, the most common presentation is groin pain, but it can be any other pain around the hip, the buttock, anywhere down to the knee. You have bone-on-bone arthritis. You have trouble not just with running or sports activities, but also with performing daily tasks of your normal day. You have difficult time dressing or putting on shoes, putting on socks. You have pain with standing for prolonged periods of time or walking. You can't walk as far as you used to because of the pain. And really, if you can no longer do or enjoy the things that you want to do or you used to do. really you should ask yourself the following question, and this is the question one of my mentors at the Mayo Clinic where I did my fellowship would ask every patient prior to surgery. And that's this. Is your pain, is your quality of life, and your activity limitations significant enough because of your hip pain that you want to undergo an operation? If the answer to this question is yes, then that's the time to consider hip replacement. If it's no or I'm not sure, it takes you some time to think of the answer, then you're probably not quite ready for hip replacement. Hip replacement is a highly successful operation with greater than 80 up to 90% survivalship at 20 years. It can improve hip range of motion, how far you can walk, your overall function, and your quality of life. This hip is not going to be the same hip that you had when you were 20, but it'll be much better than the arthritic hip that you had before. What about some anatomy of a total hip replacement? This radiograph or x-ray kind of shows a hip replacement here. The cup or the rounded part there at the top, that's what's called the acetabular component or the cup. The femur is a part that goes, the femoral component or the stem is a part that goes inside your femur. And the bearing surface is represented by the arrow to the right, and that's typically a plastic or a polyethylene. And the rounded head is usually either metal or ceramic, or sometimes if you have a higher risk of dislocation, you can have a special liner, which is a metal liner with what's called a dual mobility head with a head with two articulations. The picture to the left is a picture of a standard hip replacement, which would be fixed without cement rather. You see that gritty looking surface at the top of the stem. That's where you get a nice press fit of the stem at the time of surgery, and the bone interdigitates to become even more well fixed over time. The diagram to the right shows a cemented stem, which you would use for patients that are older with thinner bone cortices or more osteoporotic bone. And in this situation, the cement is the thing that interdigitates with the bone and then fixes around the femoral stem. There are a variety of approaches that can be used for a surgical approach to a hip replacement. There's the anterior or the direct anterior approach. There's an anterior lateral approach, a direct lateral approach, and a posterior or a posterior lateral approach. The most common of these are the direct anterior and the posterior lateral approaches. The anterior approach is not new, but it is becoming much more mainstream, and it is associated with a lot of marketing. The posterior is the most commonly used approach, although at the most recent meeting of the American Association of Hip and Knee Surgeons, in a poll of the members present at that meeting, for the first time, direct anterior approach is more prevalent than the posterior approach. The anterior lateral approach has been abandoned by most newer surgeons given a post-operative limp, but it has the best stability and can be considered particularly with patients with a very high risk of dislocation. Beware of misleading advertising. Here's a chart showing a comparison of an anterior approach to what's described as conventional surgery. And if you look at this, you would think that the best way and the be-all, end-all way to do the surgery is an anterior approach. In all reality, the anterior approach and the posterior approach both have excellent functional outcomes. A well-done surgery is a well-done surgery. The major studies, probably the best one, is a randomized study out of the Mayo Clinic, which randomized patients to an anterior approach or a posterior approach. And the main difference that was found was slight early functional improvements at a few weeks, a few extra steps, and a shortly decreased time of coming out of an assisted device like a cane. At 3 months and longer, there was no difference in functional outcomes. The risk profile is a little bit different. There's typically less hip precautions with anterior approaches, but a slightly higher risk of fracture. With a posterior approach, there's a similar functional outcomes as with the anterior approach, but a slightly higher risk of dislocation. These days, rapid recovery is becoming much more possible. Discharge from the hospital on the first day after surgery and even same-day surgery is now not only possible, but being frequently done. Patients are recovering quicker, and getting back to activity sooner? Is this a change in technique or a change in mentality? Honestly, it's probably a little bit of both. So what is necessary and what is needed? Really patient education, and this starts from the time you meet your surgeon in the office before surgery and start to establish these expectations. There's a good preoperative joint class that gives you a lot of good information about what to expect around the time of surgery. The goals between the surgeon, the patient, and the family have to be well aligned. Minimally invasive surgical techniques also help facilitate this, as do multimodal pain protocols. Use of different pain medications that work together to minimize side effects and avoid heavy use of narcotics. Good anesthesia is important, and really healthy patients with few medical problems. Same-day surgery isn't for everybody. So you may ask yourself, how long will my hip last? Will it just wear out? There's a newer ultra-high molecular weight polyethylene, or really that's just a plastic that came out about 20 years ago or so. Prior to this, there was a lot of issues with wearing of the plastic over time. With this new plastic, that really isn't an issue that's seen commonly anymore. What are the most common causes of failure? That's dislocation, where the ball pops out of the socket, an infection, fracture or breaking the bone around the implants, or loosening of the implants over time. So a realistic expectation is you have a 1% risk of failure per year. So why should you come to HOI for your joint replacement? Almost every study shows outcomes are related to surgeon volume and hospital volume. And HOI is the highest volume joint replacement center in California. We have a system that everybody knows. It optimizes care with good pathways, and deviations from normal are quickly recognized and fixed. So in summary, joint replacement is highly successful in appropriately selected patients. New does not always equal better, but innovation is important. And volume does seem to correlate with quality. Systems, pathways refined over time, with deviations quickly recognized. Thank you very much for your attention this evening, and I'll welcome any questions at this time.
We're just waiting for questions. Do you have any frequently asked questions?
So while waiting for questions, one thing people commonly ask is, what kind of recovery can I expect after a hip replacement? And you can think about this recovery period in terms of threes, 3 days, 3 weeks, and 3 months. So typically around 3 days after surgery, you're getting around the house fairly well. Usually after 3 weeks after surgery, you're getting around the house, the town, the grocery stores fairly well. And by 3 months, you're nearly fully recovered, although you do continue to make improvements for up to a year after surgery. The other thing you might have a question of is, how soon can you return to driving? And every surgeon has different criteria as far as that goes. And for me, it's 3 things. And those 3 things are, you have to be off the walker onto a cane, you have to be off your narcotic pain medications, and you have to feel comfortable to drive. Once you've met all those 3 things, then you can go back to driving. The other thing you might want to ask yourself is, again, we've talked about this today, but when is the right time to consider surgery? And there's a lot of factors that go into it. One is how much of your daily life is affected. Because even if you have signs of arthritis on your x-ray, we don't make decisions to treat just based on arthritis on the x-ray. It has to do with how functionally limited you are on your daily life. That's the most important thing. You also want to make sure you're ready, with your daily life to undergo an operation and the recovery that it's entailed, and you've really thought about everything, and you're confident and sure it's the right decision for you. Well, thank you very much for your attention today. I really appreciate it. Hopefully you learned something from this talk, and whether it's me or some other surgeon that you want to discuss your hip replacement with, if you have any questions, it's important to ask, because if you don't ask the question, you can't get an answer. So make sure you ask your surgeon any questions that you have before considering surgery. Thank you very much, and have a good evening, everybody.